Thanks for joining me today. My name is William Reisacker, and today we're going to be talking about finding the endpoint. Now, you may be asking yourself, well, what is the endpoint? Well, it's good that you're watching this video, and I'm hoping by the end of it, you won't be asking the same question. So what are the purposes of intradermal testing? Well, this can be used as a primary allergy test. You can also use it to confirm a negative prick test result where the suspicion is still high. We use this also to perform vial safety testing. And we also use it to determine the starting point for antigen-specific immunotherapy. What we want to do is we want to minimize the time that we have to escalate the patient to get them to the maintenance level, but we don't want to sacrifice safety in order to do that. So to accomplish that goal, we want to determine the endpoint for each antigen. So the endpoint is used to formulate the treatment vial for patients undergoing SCIT, subcutaneous immunotherapy. And for that, we need multiple dilutions of the allergen. So when we're doing intradermal testing, we use about 0.01 to 0.02 mLs into the dermis, and that we use to get a 4mm wheal. And we've talked about this in previous videos on skin testing. We wait 10 minutes. And the wheal generally spreads out to 5 millimeters by hydrostatic pressure. Now, a positive wheal has a central white, well-defined circular area, at least 7 millimeters, so that's 2 millimeters more than what we would consider a negative wheal, generally with a flare surrounding it, although we don't measure the flare as part of the testing procedure. Now, a negative wheal is going to be anything less than 7 millimeters. It generally does not have a flare, and it kind of loses its definition. Okay, so this is familiar to us. We've seen this before on a previous video where we talked about making 5-fold dilutions. We have our board ready when we're doing intradermal testing. We have all our dilutions present on our acrylic board with the number 6 dilution all the way to the left as a convention and the number 1 all the way to the right side. So what exactly is intradermal dilutional testing? So this helps us determine which allergens belong in the treatment vial. It also allows us to determine that safe starting point for specific immunotherapy. So again, we're trying to minimize the time required to get up to maintenance. We could start at a very, very dilute point, but it'll take a long time to get up to maintenance, and your patient may grow a bit weary waiting for some symptom relief to occur. But we don't want to sacrifice safety by starting them at too concentrated a dose either. We always use positive histamine control and a negative diluent control along with intradermal dilutional testing. And the concept is really to inject increasing concentrations of our 1 to 5 dilutions until a wheal 2 millimeters larger than the negative one is produced. So that's considered our endpoint. But we don't really stop there. What we want to do is we want to see that that endpoint is able to initiate progressive whealing. So we want to see that a wheal from the next stronger concentration should also be at least 2 millimeters greater than our suspected endpoint, and we call that our confirmatory or our confirming wheal. So the definition of our endpoint in a nutshell, the endpoint is the first positive wheal that initiates progressive whealing, and each word in that statement is very important. So the positive wheal must be at least 7 millimeters in diameter. And in order to determine the progressive whealing, we want to place our confirmatory wheal 1 dilution stronger, so that's 1 to the right, than our suspected endpoint. And that result has to be 2 millimeters greater. So let's take a look at what a typical testing field looks like with intradermal dilutional testing. So this is one of the most common locations that I use for intradermal dilutional testing, the upper part of the arm on the side. There's a lot of real estate here to do your testing, although generally I'm not going to test more than 7 or 8 allergens on a particular session. It's a little bit much, and you just can bring the patient back on a different day to do the rest of it. Now, some important concepts here. You always want to label 6, 5, 4, 3, 2, 1 and have a good idea of where your dilutions are being placed. Up at the top, I generally use my controls, so histamine, diluent, and then glycerin. And then below, I have labeled all my allergens. Sometimes you use a few letter code. So here, cat and D. farinae, one of the dust mites, alternaria, white oak. So you can use whatever definitions and whatever abbreviations you like, as long as you know which allergen you're placing into the skin. That's very important. Now, this can also be done in other areas of the body, for example, the back. So here you can see intradermal dilutional testing being performed in the back, and back here there's even more real estate than on the arm. But one of the most important concepts, just to reinforce with intradermal dilutional testing, is you want to give yourself enough room. You want there to be at least 2 centimeters in between each wheal. Otherwise, one wheal's reaction can start influencing another wheal's reaction. Now you can see sometimes it looks a little bit scary as you're going through, but it generally looks a lot worse than it feels. And after you're done, you spray them with a little bit of spray Benadryl, and if they're feeling itchy, they could use a cold compress or an oral antihistamine as well after the testing. Okay, so what are our wheeling responses going to be? Well, our typical one is going to be a negative wheal, the 5 millimeter. Then we're going to get a 7 millimeter, and now we're suspecting that this is going to be our endpoint, but then we put on a confirming wheal. And then if we see that's 9 millimeters, 2 millimeters greater than the suspected endpoint, we're done. And we know that that dilution, whichever that dilution is in the middle, is our endpoint. Now let's look at some abnormal wheeling responses, because you don't always get that easy 5, 7, 9 sequence that you're looking for. Sometimes you'll get a plateau, which means you'll get 5, then you'll get 7, and then you'll repeat the stronger dilution, get another 7, and then you'll get your 9 millimeter. Now, when you're looking at this, you'll say, well, which one is the endpoint? Is it the first 7? Is it the second 7? Well, it's the second 7 millimeter wheal, because that's the one that initiated progressive wheeling. So whichever dilution that is your endpoint for that allergen. Sometimes you'll get what's called a flash response, which means you'll get a negative, and then you'll get a ginormous wheal, and this is the diameter of the wheal we're talking about. You can't really interpret that. You can't call that your endpoint, and you certainly don't want to put a stronger allergen after you've gotten one of those. Occasionally, these flash responses can obliterate your entire field, and at that point, it's really best to stop for the day. Either bring the patient back on another day for repeat skin testing, or do in vitro testing on them as well. Okay, so let's take a look at an example of an intradermal dilutional testing session. So here we see we've placed the number 6 dilution, which was negative. Then we placed the number 5, that's also negative. Then number 4, we got a 7. So now we're suspecting we've got an endpoint on our hands. So we've placed the confirmatory wheal, and indeed we've seen that initiated progressive wheeling. So now we can conclude that for that allergen, the endpoint is a number 4. Okay, so these are the controls that are used during intradermal dilutional testing, or IDT as we call it. The first one is histamine. So that also comes in a concentrated solution, and we make 5-fold dilutions of that in a very similar way that we make 5-fold dilutions of the concentrated allergen. And for IDT, we use the number 3 dilution as our positive control. For the negative control, we use our diluent, which is just phenylated saline, which doesn't really have a number designation, but certainly if they come back positive, that would indicate that they're very sensitive. The skin is too sensitive really for testing. And then, of course, we use glycerin, which is one of our most important controls. At the beginning, we place a number 3 glycerin. And again, this is a number 3 dilution that's created from our stock solution of 50% glycerin, because as you recall, our concentrated allergens also come in 50% glycerin. But we also use a matched glycerin control if we're going to place any number 2 or number 1 dilution allergens, because at this concentration of glycerin, sometimes the skin can react just to the glycerin. And what we want to see in our matched glycerin control, in order for it to be positive, is that our allergen wheal has to be 2 millimeters more than the matched glycerin control wheal. Now, glycerin reactions are very unlikely once you get beyond dilution number 3. So when you're testing allergens at number 6, number 5, and number 4, there's no need to place a matched glycerin control. Okay, so let's look at another example. Here we have our board, or essentially what our arm is going to look like. And on the histamine, we see a good reaction to a number 3. So that's a number 7. Just like when we do our skin prick testing, we like to see a 7 millimeter wheal on histamine. For the diluent, that was negative, which is good. So the patient isn't overly reactive. If they react to diluent, then you're suspecting perhaps dermatographia. And then we've put our glycerin controls. We started out with a number 3, which was negative. Also a number 2 was negative. But here you see that a number 1 glycerin produced a 7 millimeter wheal. So there is a bit of glycerin sensitivity going on. And now we compare that to our dust mite treatment, our dust mite testing rather. So we've placed a number 4, and that's negative. We placed the number 3, that's also negative. Now we've placed the number 2, and that produced a positive wheal, so we're suspecting an endpoint here, and we've also placed the matching glycerin control, and we see that it's 2 millimeters greater than the glycerin control, so we know that the person's actually reacting to the dust mite allergen, not just the glycerin. And now we've placed our number 1 confirmatory wheal, and again, that is 2 millimeters greater than the one before, so it's a good confirmatory wheal, and it's also 2 millimeters greater than the matched glycerin control. If the matched glycerin control was 9, then you would have to conclude that that was actually a negative test for dust mite, and then there would be no endpoint. But here, because we have a 7, then a 9, we have an endpoint of number 2. Now, one thing of note, if you get a 7 on a number 1, would you place a concentrate as a confirmatory wheal? And the answer is no, because we never want to do intradermal testing with concentrates. You could just presume that, well, maybe this is just a number 1 endpoint and then use that as your treatment. And this is a bit controversial. Some doctors will treat what they presume is a number 1 endpoint. Many doctors will not put those in the vial, assuming that, well, the allergen was just so concentrated that it caused a reaction in the skin, and many people will not include that in the treatment set. So let's look at another example. This is tree. So we've placed a number 4, a number 3, and a number 2, and we've got negative wheals on all of those. So now we're really running out of options here. We place a number 1, and we get a 7 millimeter wheal. So okay, that's a positive wheal, but if you look at it compared to the glycerin control, the matched glycerin control, it's the same, which means that the person's not reacting to the tree antigen. They're actually reacting to the glycerin that's in the dilution vial. So this would not be considered an endpoint, and this one would not be considered as a candidate to go into the treatment vial. Okay, so no endpoint on tree. Now, can we get the endpoint from serum-specific IgE? Well, we can, because as you recall, many people cannot be skin tested. Their skin is too sensitive with dermatographia, or they have chronic dermatitis. They can't come off antihistamines. Some children, it's not really practical to do extended skin testing on them. So we can determine our endpoint from serum-specific IgE, and we use the immunocap classes for this. The rule we use is to take the class, and then we move the result 1 jump to the left. So that's in the more dilute direction, and this we consider the endpoint. This is just a safety measure that's taken. So here we see our immunocap classes based on the level of IgE in the serum. And the more IgE in the serum, the higher the class designation is. Now, there are also some blended techniques. These are ways to combine skin prick testing along with intradermal testing. And there's also ways to create some shortcuts, so you don't have to use 6 dilutions of every antigen for testing. For example, we can start based on the skin prick testing grade. So if it's a 3 or a 4, we could start our intradermal testing at the number 6. But if the skin prick testing grade is a 1 or 2, indicating that it's less of a sensitivity, then we could start at a little bit more of a concentrated point, so we could start at a number 4. And as we know, that if we have a negative skin prick test and we're confirming that to make sure that that truly is, the patient is truly negative to that allergen, we'll place a number 2 as just a confirmation of that. There's also some extrapolation techniques So for example, if we have a 5mm wheel on the left side of the board, then we can skip the next dilution and actually put the one after it and then extrapolate the results in between. Because if you think about it, if you have 5 and then you skip and then you get a 9mm wheel, we would have had to put that one on anyway as a confirmatory. So we can just put the 5, the 9, and then extrapolate the 7 in between. Then there's also modified quantitative testing, which is an example of another blended technique. So here we see modified quantitative testing, or MQT, which is one of the blended techniques. And this involves first putting on skin prick testing. So the multi-test 2, and then you measure the results of that. And based on the diameter of the wheel, that determines which dilution of the allergen is placed on in an intradermal test. So it's one skin prick test and one intradermal test, and then based on the results of that intradermal test, if you follow it down the tree, that determines what your endpoint is. Now on the next slide, we have some examples of intradermal dilutional testing, and I'd like you all to take a minute to try to determine which one will be the endpoint. Okay, so let's see how you did. Let's take a look at the top one, Timothy grass. Well, here we can see we have a little bit of a plateau situation, 7, 7, 7. Then we get to a 9. So now our suspected endpoint is number 4, and we look at our glycerin, and we're good. We have a matched glycerin control, so number 4 would be the endpoint for Timothy grass. Now let's look at alternaria, the one below. We have 5. So then what we did is we did an extrapolation. We skipped the number 3 and we put the number 2 dilution on. We got a number 9, a 9mm wheel, which is fine looking at it compared to the matched glycerin control. So now we can extrapolate a 7 in between, which would mean that number 3 is the endpoint for alternaria. Let's look at D. farinae. We got a 7, and then we got a 13, which is a very large jump. So that we would consider a flash reaction, and we wouldn't be able to interpret an endpoint from that. Now let's look at cat. We put on a number 6, and we got a negative number 5 millimeter wheel. So then we extrapolated. We skipped the number 5 dilution, and we put the number 4 dilution. So we got a 7. Okay, well that's a positive one, but we can't really extrapolate anything in between, except perhaps another 5 or maybe a 7. So now we'll place a number 3, and we'll see if we get a confirmatory wheel. And lo and behold, we get another 7. So now we're looking like we have a plateau. And again, we get another 7 on number 2. So we do indeed have a plateau. So then we place a number 1, and we get a 9. So that would look like the confirmatory wheel, but then we have to look at our matched glycerin control, and that's also 9. So we really have no endpoint on cat. So that one does not belong in the treatment vial. Now let's look at cockroach. Again, we get a 5. We get a negative wheel for 6, and then we extrapolate a bit in between. We place a number 4 and get a 9. So we can call number 5 the endpoint for cockroach. And then we'll look at dog. It doesn't always have to be an odd number. You can get even numbers too. It's just whatever you measure it at. So we put a number 6, and we get an 8mm wheel. So then that would be a positive wheel, and we're suspecting that's the endpoint. So let's put a confirmatory wheel on number 5, and that is 2 millimeters greater. So we can call that a confirmatory wheel, and then we can label number 6 as the endpoint for dog. Okay, so I hope you've all enjoyed this journey into finding the endpoint, and look out for the next video, which is going to be on immunotherapy, vial prep, and escalation.